Okay. So it's just before the 3 o'clock hour. Thank you for joining us for the next to the last session in today's Topics in Breast Cancer Conference hosted by the Oregon Cancer Foundation.
And I'm going to take this opportunity to thank our sponsors once again. So we have Caris Life Sciences, Myriad, Oncotype DX, Seattle Genetics, and Eisai. And we wouldn't be able to put this on without them. So thank you guys so much.
So for those of you, I think everybody, most everybody at this point has attended at least one other session today, so you should all be familiar with the format. But just in case we have anybody new who is joining us, there should be 3 buttons at the bottom of your screen. There's a raise your hand button, a chat button, and a Q&A button. If you have technical difficulties, go ahead and click that raise your hand button, and either Katie or myself will be happy to help you. If you'd like to chat with the panelists or with other attendees during the presentation, you can do that through the chat feature, and questions can be submitted by clicking on the Q&A feature. My name is Amy Johnston, and I'm the director of the Oregon Cancer Foundation, and it's my pleasure to welcome you here today. I'll be one of your facilitators, as will Katie Burke. Katie is our Breast Cancer Resource Coordinator here at Oregon Cancer Foundation. And Katie, with that, would you like to introduce our speaker?
Yes, I would love to. So today we have Dr. Cho, that is a medical oncologist at Willamette Valley Cancer Institute, and he has a very special interest in breast cancer. He is an active member of the U.S. Oncology Breast Cancer Research Committee and enjoys teaching medical students. So I had the privilege to work closely with Dr. Cho for many years, and he's a great individual. So take it away, Dr. Cho.
Well, thank you, Katie. Let's see. First of all, I want to thank the Oregon Cancer Foundation for inviting me to speak. What a great organization, and we see the Oregon Cancer Foundation impact my patients on a daily basis. So for all the work you do, not only you, Katie and Amy, but the whole team over there, thank you. Thank you from all my patients. So let's see, I have to try to, am I able to share my screen here?
Yes, you should be able to.
Easier said than done. We just
I know you have a complex.
Oh, there you go. I just needed to expand it. Sorry about that.
All right.
Okay, here we go. You guys see this? So this is also new for me to present in Zoom. So bear with me if I'm not quite used to not seeing the people in the room. So welcome. As Katie said, I'm a medical oncologist here in Eugene, and I'm hoping you'll learn a bit about recurrence and metastatic breast cancer. Okay, so I'm not paid by any pharmaceuticals. That's a good thing. And another caveat I want to note is that I do have one patient that I'm presenting that is on a non-FDA approved treatment. So I'm not condoning to use that, but it is an example of therapies that we may use in the future. Okay, as you all know, breast cancer is common. 1 in 8 women in the United States will be diagnosed with breast cancer in their lifetime. So by far, most breast cancers are local and they have not spread. Well over 80%, and most early stage cancers, well over 90% don't have their cancers coming back. So if you have or had breast cancer in an early stage, I'm not saying that this will happen to you, but I want people to feel comfortable if they have metastatic disease, or at least to know what process that we go through. So I want to present a patient. This is Mrs. Jones. Mrs. Jones is either one of two categories. She had breast cancer a few years ago, and she's just not feeling well, or she just recently felt a breast mass, and she presents either to my office or primary care doctor's office, and has some concerns. She's had lost a lot of weight, and she's having a little problems breathing, and she has bone pain. And me as a provider, as all of you know, and for those of you who are my breast cancer patients, I ask all the same questions at my breast follow-ups. Do you have any unexpected weight loss, appetite changes, bone pain, headache, shortness of breath, cough, coughing up blood, lumps or bumps, or new masses? And if there are any yellow or red flags, then we go to the next step here. So how do we make the diagnosis? If there's any concern, either for the breast cancer coming back locally or spread to other places, we do full staging scans. And what does that mean? We do a CAT scan of their whole body, and either a bone scan to check all the bones, or a PET scan, which is a sugar labeled dye that looks at activity of cells. Also, we talk about headaches or stroke-like symptoms. If there's any concern for that, we get an MRI of the brain too. So I teach my medical students, tissue is the issue. Even if we have a patient who has had breast cancer, it's really important to get a biopsy of the cancer. 25% of the breast cancers that come back can have different set of markers than the original disease. It still came from that original disease, but it can change over time. The next thing we do, we consider doing some testing on the tissue. Sometimes we don't do it right at the diagnosis, but maybe later on after we go through the first treatment. There's something called next generation sequencing, where we actually take the cancer itself and analyze the DNA to see if there are enzymes or other features of the cancer that we can treat and block. As Catherine Murray talked about, we sometimes talk about genetic testing, as we have some treatments for patients who are BRCA positive. We do routine blood tests. We check their liver, kidneys, bones. We check to see if they're anemic, and there are some cancer markers we can track to see how our therapies are working going forward. They're called CA2729, which is what I do. Some other providers also do CA15-3 and CEA. Now, after we get all this information to see how far the cancer spread, we place the cancer in one of three different types. So hormone positive, is it fueled by estrogen? Does it have strongly estrogen receptors? I call them little catcher's mitts for estrogen. And that means that the breast cancer is fueled by estrogen. Is it HER2 positive? About 20% of the breast cancers have a protein marker on the cell that causes it to grow very quickly. And in the past, these were very, very aggressive cancers, but we have lots of new treatments for these types of cancers. And is it triple negative, meaning it does not have that estrogen receptor, and it is also not HER2 positive? Okay, let's go back to Mrs. Jones. I'm not sure if you can see my pointer here, but we did a CAT scan of Mrs. Jones. And by the way, it's not a real patient, but And in her lungs, I call them little gumballs here, we see this very round area in her left lung. That makes it concerning for breast cancer that's spread. And as we go forward, we do a bone scan. And this is looking at all the bones. And these black areas are areas concerning for breast cancer that spread to the bones here. Okay. Once we make the diagnosis, we talk about endings. And it sounds strange and it sounds depressing, but really not. It's really important to talk about endings at the beginning because if we don't talk about it at the beginning, sometimes it's very, very difficult to talk about it towards the end. We talk about breast cancer that spread is not curable, and we talk about the differences between treating cancer that is curable versus a palliative approach. For a curative cancer, we're gonna, I don't really care, of course I do, but we're gonna make patients feel really sick sometimes in order to try to wipe out the cancer. And in a palliative situation, our goals is to make the patient feel the best they can feel. Remember, the goal is not to cure the cancer. In the past, we've tried to do really high doses of chemotherapy and a bone marrow transplant, and we found it actually made patients more sick, and we actually didn't cure the patients. So what I like to do is I like to talk about chocolate and football. Now there's a book called Being Mortal by Atul Gawande. And in it, he talks about healthcare and health treatment. And most of the times they're the same, but some of the times they're not. He talks about one of his colleagues whose father had prostate cancer that spread to his bones. And the father was a really smart guy. He was a professor and wrote lots of books and articles. So the daughter went to the father and said, "Hey, Dad, I need to know what's important to you. Down the road, we may need to make some decisions together. So it's really important to know what's your quality of life." And what the father told the daughter really surprised her. He said, "Honey, as long as I can eat my chocolate and watch Sunday morning football, I want everything done." So true to his word, he had some painful surgeries, and there was a time where he was paralyzed. And but during this time, he could eat his chocolate and watch his football, and he was happy because that's what was quality of life to him. Eventually, there was a time where he didn't eat his chocolate and watch his football, and he didn't want any more treatments done because he lost what was important to him. So we talk about this way at the beginning. We talk about what's important, what is their quality of life, and that is our number one priority. We want patients to have more good days than bad. And our second priority is quantity of life. Okay. The next thing we also talk about is that stable disease is a win. Now, again, we're not trying to wipe out all the cancer. If people are having more good days than bad and the cancer's not growing, that's a win. And it means we're keeping things under control and we don't have to use more tools in our toolbox. Now, the next thing, and there's a lot of research that shows this, we talk about if the cancer grows through 3 different types of treatment with no response, the 4th one's not likely to be effective. And so we make it clear that, hey, we don't want to punish patients because their disease is aggressive. So if the cancer grows through 3 treatments and it doesn't touch the cancer at all, the 4th one is not likely to be effective. Okay. Let me talk about our toolboxes, and we'll talk about these individually. Most people think of chemotherapy or cancer treatment as only using what I call the atomic bomb treatments. They're called cytotoxic chemotherapy. It was actually discovered after using nitrogen mustard gas in the 40s as a treatment for lymphoma. And those are treatments that are not specific to cancer cells, and they have some collateral damage. The next thing we'll talk about is endocrine therapy. The reason why I show a dog there is that the way they found out that certain cancers are fueled by hormones is that in certain dogs with prostate cancer that spread, if they take out their testicles and decrease their testosterone, they've realized that a lot of these cancers would shrink away. And that was the start of looking at what I call hormone blocking treatments. And about 20 years ago, we started to realize that cancer is driven by certain enzymes. And there are certain proteins under the cancer that we can target. And so we started thinking about tailoring treatments specifically for cancers and instead of trying to treat cancers indiscriminately. The most common thing or the poster child for this is a pill for leukemia called Gleevec. And really it blocks an enzyme and it changes their cancer to something like high blood pressure. And then we'll talk about immunotherapy. And then this is Jimmy Carter, where he had a type of immunotherapy for his melanoma, where he used his own immune system to fight cancer. Okay. So let's talk about the atomic bomb type chemotherapies. We call it cytotoxic chemotherapies, and there are many, many different types. Basically, the way these work is that it gets into the process of cells dividing. And as you know, in our day-to-day body functions, a lot of cells divide for very good reasons. But our goal with this type of cancer treatment is that we would affect the cancer by far more than our healthy tissues. There are a lot of advantages with this type of chemotherapy. Let's say if there's a cancer that's growing really, really quickly, or it potentially can cause organ damage, such as liver or lungs, or something maybe pressing in the spinal cord, and we want the cancer to shrink down very quickly. So usually if we're in a circumstance like that, then this is one of the first tools that we this is one of the first tools that we use in our toolbox in that situation. And it's not specific to any specific cancer. So if, let's say there isn't a specific enzyme, or if it's not fueled by estrogen and there's not a specific protein, this is maybe one of the tools that we use first. Now, there are drawbacks to these, of course. There's more side effects than more targeted treatments. Low blood counts, damage to the immune system. Many of these, not all, are through the IV, and we can't give these things forever because over time they tend to make your blood counts slower and slower to recover. And cancer is smart, and I describe cancer like bacteria and antibiotics. If you can't wipe out a cancer bacteria with antibiotics, it will soon grow resistance. And so cancers can learn to grow resistance to this type of therapy. Endocrine therapy. So I call these hormone blocking therapies. We all make estrogen. I make estrogen. I make estrogen in my fat tissues and the glands above my kidneys called adrenal glands. And we all have estrogen molecules floating around. And we know that many, if not most, breast cancers have these catcher's mitts for estrogen called estrogen receptors. And our goal with this type of therapy is trying to prevent estrogen from getting into the estrogen receptors. And we have several types of treatments for this. A category called aromatase inhibitors that block an enzyme that makes estrogen. A shot called fulvestrance that causes a cell to degrade these estrogen receptors, and tamoxifen, which blocks the estrogen receptors. These, if breast cancer is fueled by estrogen, are usually our first line of therapy because they're really well tolerated. They have limited side effects. They don't push down the immune system, and they can be taken for years. Not only that is things like anastrozole and tamoxifen, they're cheap and usually, even without insurance, less than $20 a month. Some cons, I mean, you do need to have that estrogen receptor in order to start with this type of therapy. So it doesn't work on all breast cancers. The next type of therapy is called targeted therapy. Means that we look at a specific feature of the cancer to see if we can block or target. Now, the first part I would like to talk about is called antibody therapy. I think all of you know what antibodies are. So if you get the flu shot, you don't get the flu virus, you get some flu proteins. And what happens is your immune system makes these little missiles called antibodies to the flu proteins. So the next time you get the flu virus, these proteins cover the flu virus and your immune system helps wipe them out. Antibodies can also block certain signals in the cancer from triggering, so it can block the process of growth. The most common and most used antibody for breast cancer is something called Herceptin, and that's what blocks a protein called HER2 in the cancer. We found its sister antibody called Perjeta that also works. And we became a little smarter down the road, and we were able to link a molecule of chemotherapy to these antibodies with a special protein called a linker protein that is what I call a smart bomb. And basically, what this does, it brings that molecule of chemotherapy directly to the cancer, where it's then released, and then you don't have as much collateral damage. It hopefully kills that cells or even a couple cells around it, and hopefully spares healthy tissues. And initially we only had one of those, but we're having called aldotrastuzumab or Kadcyla. There was another one that literally was just FDA approved called Enhertu or trastuzumab deruxtecan, and sacituzumab, which also called SASI, for that is one for triple negative disease. Most of these are well tolerated. They don't have as many side effects as the atomic bomb type chemotherapies. And the advantage is not only does it elicit an immune response, but it can also block those pathways. Now, most of these, in the past, they were all through an IV or a port. We're actually getting more and more of these that you can just put under the skin. We have to monitor people's heart to make sure their heart pumping functions are okay. And certain of these can have sort of these idiosyncratic reactions. The newer smart bulb called Enhertu or trastuzumab deruxtecan can cause inflammation of the lungs, so we have to watch out for that. This is Barbara Bradfield. She had metastatic HER2 positive disease. I believe it was when she was in her 30s. She had gone through all the atomic bomb chemotherapies and really didn't have any other options. She didn't want to do any more. She was one of those brave women that raised her hand and said, hey, you know, I'm going to participate in this research trial called looking at a new antibody back then called Herceptin. She's disease free, and I believe it's almost 25 or 30 years at this point. So she's definitely one of my heroes. The next category in targeted therapy is enzyme blocking medications. You've probably seen commercials of this all the time on TV and something called Ibrance. So there are many, many different enzymes that causes cancer cells to divide. And these are sort of like a key and a lock, or it basically blocks the enzyme that causes these certain cells to divide. And there are a variety of different ones. And the drawback for these is that you have to have those specific enzymes. For hormone positive breast cancers, they have a lot of these enzymes called cyclin-dependent kinases. We also look for BRCA1 and 2 patients that these enzyme blocking medications called PARP inhibitors work on. In HER2, there are medications called lapatinib, neratinib, and tucatinib that can block enzymes for HER2 patients. And we're starting to look for these last one, although they're pretty rare. They're called NTRK, where we have enzyme blocking treatments called NTRK inhibitors. The advantages, there are pills, well tolerated. Some, sometimes you can get a rash or high blood pressure or diarrhea, but we can use this for long periods of time. However, they're new. They need a specific change in the DNA or the enzyme defect, and they're very, very expensive. They can cost $10,000-15,000 a month, although most patients don't pay that out of pocket. You can see symptoms like high blood pressure, diarrhea. We have to follow blood counts, and for certain medications, like Piqray or Alpelisib, we have to look out for diabetes. Jimmy Carter. Jimmy Carter had melanoma that spread to his liver and his brain. He had some surgeries and radiation, but he used back then a new type of therapy called immune therapy. And I believe that was about 5 years ago, maybe 6 years ago. And as far as I know, he is cancer-free. Now, let's talk about that type of therapy, and it's changing the way we think about cancer. I usually start by saying that we all have cancer. And whenever you're dividing a billion, multiple billion letters of DNA to another cell, mistakes are going to be made. And these mistakes can cause cancer cells. So in that process, we all develop little cancer cells in our body. And we have these little immune cells called T cells that look out for cancer cells and wipes them out. And sometimes cancer cells can hide from the immune system by showing a protein I like to call a checkpoint. And so those immune cells check every cell. So are you part of me? Are you part of me? Part of me? Oh yeah, you're part of me. And the cancer goes unchecked. There are certain antibodies called checkpoint inhibitors that block those checkpoints. And so that uncloaks the cancer, and the immune system can see the cancer again. And that's one of the things that Jimmy Carter had. He had something called pembrolizumab or Keytruda. And it's pretty exciting. In the past, this was not very useful for breast cancer, but we're looking into coupling it with other therapies. There are more experimental treatments for immune therapy where you take the cancer and you isolate those little immune cells, those T cells. I call them little Davids against a giant Goliath. And then we multiply them out of the body 1 billion times and inject it back in. And we found that in certain cases, although it's pretty rare, and this is a very experimental and time-consuming process, that we can wipe out the cancer that way. Now there's a newer type of treatment, and again, super experimental, and we are only starting to look at breast cancer recently, although it's FDA approved for leukemia and lymphoma, and we have research trials here at WVCI for that, is a treatment called CAR T therapy. It's taking your own healthy immune cells and using a virus to change them so they can recognize your specific cancer and injecting it back in. And for our leukemia and lymphoma patients, it's doing some pretty incredible things. And in research trials, we're looking at different markers on breast cancer to target these T cells. So in general, immune therapies are pretty well tolerated, but it doesn't mean that all cancers will respond to these immune therapies. If they do, it's really exciting. And we're seeing patients that we would have never seen live sometimes for years at a time. Now, the cons, sometimes it can trigger the immune system to attack healthy tissues. So you can have some autoimmune type issues, like with thyroid issues or with diarrhea or inflammation of the lungs or liver. And at this time, immune therapies don't work with the majority of breast cancers. So what's next? Now, because breast cancer is normally not recognized by the immune system, we couple immune therapies with chemotherapies. So this is one of my patients who had triple negative breast cancer that had the cancer come back in her armpit area. And it was in a situation where it was wrapping around nerves and blood vessels, and it couldn't be removed surgically, and she couldn't get any more radiation to that area. So we gave her a chemotherapy called Abraxane and one of those checkpoint blockers or checkpoint inhibitors called atezolizumab. And 3 months later, the cancer started shrinking down. and she decided to stop her treatment, and we brought her back several months later, and even off of treatment, her immune system continued to recognize the cancer and continues to shrink down the cancer. This is another one of my patients who was diagnosed 6 years ago with breast cancer that spread to her bones, and we kept doing these tools, using these tools in her toolbox until one time we got an MRI and we found these concerning changes. This is the bottom of her spinal cord, and you can see that white, it's called sugar coating or dusting on the outside of her spinal cord. And in her brain, you can see this dusting on the lining of the inside of her brain. And this is called leptomeningeal disease, where the cancer was starting to grow in the fluid of around the brain. Usually, these patients only have, maybe a couple months to live. She was getting severe headaches, vomiting, and going blind. We talked about hospice and different options, and ultimately we decided to treat with an enzyme blocking medication called abemaciclib that she was already on, and adding one of those checkpoint therapies. I call it the Jimmy Carter drug. And we placed her in hospice, and she started feeling better. And she felt so good that she went back to work. And we decided to take her off of hospice and continue therapy. And we did another MRI, and all that disease floating around in the fluid around her spinal cord was nearly gone, if not gone. And all that, those cancer cells causing the inflammation in her brain disappeared 6 months later. Again, this is not FDA approved, but there's a lot of data supporting this, and we're writing this up as an article. But this is the promise of coupling immune therapy with other therapies like enzyme blocking therapies to make something like hormone positive breast cancer more recognizable to the immune system. This is Judy Perkins, another hero of mine. She had hormone positive breast cancer and went through all the different tools in our toolbox and had no tools left. She also raised her hand and said, hey, I want to join a research trial, and knowing that it may not work, to take her cancer and isolate those little Davids and multiply them out 1 billion times and couple it with the Jimmy Carter drug and do it both at the same time. And we've never seen this before. She got both of those treatments, and now it's 4 years later. This is 14 months, and as far as I know, she does not have cancer. This is experimental. This is only done at the National Institute of Health. This is only one case, but for me, this is incredible promise that potentially in the future we will be able to maybe cure breast cancer that's spread. So let's go back to Mrs. Jones. And what do we tell Mrs. Jones about? Gosh, she has cancer that we can't cure, but we have a whole lot of different treatment options. In fact, I go to a conference in San Antonio every year, and in 2019, these are all the different breakthrough advances that we had several for each type of breast cancer that spread. And this is just 1 year. So I am very hopeful for the future here. Now, that was Mrs. Jones, but this is Shannon Doherty from 90210. And she has stage 4 breast cancer, but didn't tell anyone and went back to acting. And no one knew until there was this settlement with his insurance company and leaked out. And this is what she said. One of the reasons, along with Luke Perry, who I believe died, that I did 90210 and didn't really tell anyone, because I thought people can look at that other people with stage 4 can work too. Like, you know, our life doesn't end the minute we get the diagnosis. We still have some living to do. So take-home points, tissue's the issue. There are different types of breast cancer that spread. We need to talk about chocolate and football. We have so many different tools in our toolbox these days. And in the future, combining these treatments, especially with immunotherapy, have a lot of exciting potentials. We do a lot of research at WVCI, and this is how we make discoveries. So thank you. If you want to learn a lot more about cancer, read the book Emperor of All Maladies or watch the PBS special, and I'm happy to take questions.
All right. Thank you, Dr. Cho. That really, I've seen you present this more than once now, and it's always inspiring and gives me goosebumps and so much hope. So I know it does for our attendees as well. So thank you. And I just recently bought the audiobook for Emperor of All Maladies, and it's wonderful on audiobook as well.
Nice.
So at this point in time, we're going to open this up for question and answer. There's a Q&A button down at the bottom of your screen, and I know there are probably a lot of questions out there, so we'll give you just a couple minutes to get those questions typed in. Let Dr. Cho take a little bit of a break unless he has anything else to add. All right.
Sorry I ran a little long.
No, not at all. Dr. Cho, thank you so much again. It's, you know, I think it's really incredible. Eugene's not that large of a city, and it's really incredible that we have the quality and caliber of particularly oncology care that we do here in this community. So you could live anywhere in the country. Thank you for being here. All right, Katie, you want to?
Anywhere else.
Yes. So what about, I have questions for you. Sorry. Let me just go right in there. What about inclusion of patients with brain mets into clinical trials? I know that has been limited in the past. What do you tell patients with brain mets about enrolling in trials?
Well, I still encourage patients who has had brain mets to enroll. It really depends on the clinical trials. So several of those HER2 positive new treatments allowed patients with brain mets. And usually they require that the brain mets have been treated, usually with radiation, and that it's relatively stable disease. So don't let brain mets having brain mets discourage you from looking for clinical trials.
And then how much radiation is one exposed to when they get routine scans and contrast dye injected?
So the risk of developing another cancer from getting scans. There's a lot of debate about that, and the range actually is quite large. So one CAT scan is about getting 300 x-rays done. And one x-ray is sort of equivalent to taking a flight across the country and getting radiation exposure from that. So it ranges. The risk of getting a CAT scan, cancer from a CAT scan, is in the range of 1 in 40,000 to 1 in 200,000. I usually say don't get a CAT scan if you don't need it, but the risk is quite low that you would get a cancer from a CAT scan.
Another one commented on your talk is very encouraging. And do you use any of these treatments as in sorry, Amy's getting rid of the ones we've talked and I was having trouble following. It must be the end of the day. Do you use any of these treatments as in antibiotic therapies or immune therapies as first line of treatment?
That's a great question. Usually the way research works, it starts with the sickest patients first. And once we start proving that it works, we keep going closer to the initial line of therapy. And you're absolutely right. That's where I hope that we can get those immune therapies is right at the beginning. And that's where it could probably work the best. But we have to do research and prove and have to step it in each line of therapy. Yep. So, yep. What else?
All right. I'm guessing there are probably a couple other questions. Okay, we have a question here. What are your thoughts on doublets and triplets in treating patients?
Right.
Does a complex treatment regimen keep you from using more than one drug?
That's been studied, especially for hormone-positive breast cancer. And I have to say, every case is very unique. So it's usually recommended as long as there isn't potential organ failure, like the liver's not full or the lungs aren't full, that we use just one chemo. Because it's shown that if we use doublet or triplet chemotherapy at the beginning, we tend to use up our tools faster and the patients don't live as long. But if we need to shrink something very, very quickly, that's when we use doublet therapy. Again, there's some exceptions to that rule, but usually we try to use one chemotherapy at a time. Especially, I'm sorry, this is the atomic bomb chemo. We're looking to couple enzyme blocking and immune therapies with chemotherapies, and hope that I really do think that's the future.
So one day we may be able to eliminate chemo?
Ooh, yeah. I'm hoping. Although in some of the studies it shows that chemo can help get an immune response too. So I don't know how this is all going to unfold. I'm hoping that we can eliminate chemo. 20 years from now, I believe I'm going to be out of a job. And the way we're going to treat cancer is that, we get some cancer cells, we make those T cells and inject it back in, and then we're done. So I think at that point, we might be able to get rid of chemo. But right now, they're another tool in our toolbox.
All right. Are there any additional questions? Oh, we do have one. This is from Dr. Henderson. And well, it's more of a comment, but she says the breast surgeons think that we will also be out of a job in 20 years.
Very nice.
All right. Well, Dr. Cho, thank you. We're going to give it just one more minute and see if anybody else has a question. If you have any burning questions, you can submit them anonymously. That's fine. Go ahead and send those now. Otherwise, we are going to wrap up.
I see a quick question on chat about Oncotype DX and breast cancer recurrence. It was not designed for breast cancer recurrence, so it doesn't follow, Oncotype DX doesn't follow that indication. It's not generally recommended, though I have done it in certain circumstances.
What is the likelihood of developing lymphedema years down the road?
Well, that was more of a question of our lymphedema physical therapist a couple speakers ago. There is, of course, a risk. but I don't want that to prevent people from being active, as Andrea talked about. From my, a physical therapist point of view, they feel like there is always a risk as long as there was lymph nodes removed. But the longer you go, I personally think the better it is. And most of the times these days, as Dr. Henderson talked about, we don't take all the lymph nodes out. And so the more and more that we're doing these sentinel lymph node or limited lymph node dissections, it's actually pretty rare we see the bad lymphodemas anymore.
Where does stress come into play? How do you get family to help keep the stress down?
Oh, that's tough. So I'm all about wellness too, physical, mental, spiritual, relational. Like I talked about, a lot of my talk was focused on the immune system. And so stress can bring down the immune system. So you have to balance all these things. You know what? I just bought a bike. And everyone who works with me knows I love to ride around. Exercise is huge in helping with stress.
Come to survivorship. We'll help in the
I'll bike there.
There you go. Yeah. But our survivorship does talk a lot about managing stress and the overall worry of reoccurrence, and so.
Okay.
All right. Okay. So it doesn't look like we have any more questions at this time. So Dr. Cho, thank you again so much. And I know that you've attended quite a few of the sessions today. So thank you for participating and not only being so generous with your time for your own session, but participating in those others as well.
You're welcome.
And we have a thank you so very much from an attendee. So thank you. Thanks, Dr. Cho. Okay. All right. We have one session left today. We are going to stop this recording in just a minute. Our next session is with a very special lady. She is a breast cancer survivor herself. Her name is Charity Crosby, and she will be joining us in just about 10 minutes. We'll see you over there. Thank you.